This learning module is going to be about neuroanesthesia principles. The broad definition of anesthesia is to provide a lack of sensation, a lack of reflexes, lack of anxiety, antiemesis, meaning lack of nausea, and achieving physiologic and hemodynamic stability, such as your cardiac and respiratory, hepatic, and renal functions. In 1937, Dr. Goodell reported a system that assesses the depth of anesthesia. His system relied on a series of physiological signs, including muscle movement. Back then, they used ether as an inhalational agent, and all the patients were pre-medicated with morphine and atropine with no neuromuscular blockade. And these are his stages. Stage 1 was the induction to loss of consciousness. Respirations were present and quiet, and reflexes were intact. He named this amnesia and analgesic stage. The excitement or delirium stage was stage 2. This is where the patient had loss of consciousness to onset of total anesthesia. The eyelash reflex disappeared, respirations were irregular, and involuntary movements occurred at this time, and the pupils were dilated. There was an increased risk of getting sick here, coughing and aspiration, laryngospasms, and bronchospasms. Stage 3 is when the patient went from total lack of consciousness to total muscle relaxation. This is where the pupils were non-reactive and spontaneous respirations ceased. Stage 4 is considered an anesthetic overdose. This is where the pupils were fixed and dilated, and cardiac arrest was imminent with no respirations. This required immediate cessation of anesthetics. This is a real picture of him right here underneath the drapes, assessing the patient and doing this research. And I found this paper here. I thought that was kind of cool. This picture of his actual notes of the pupils right here and how they were fixed and dilated or restricted. Just kind of a neat picture, I thought. This classification depends on muscular movement. In 1942, neuromuscular blockade, though, was introduced to anesthesia. So a lot of his assessments went out the window because they depended on muscle movements. In 1982, they stopped using ether, which was good because it made probably the majority of patients sick to their stomach. I'm old enough to remember people having surgery with ether, and the vast majority of them were nauseated after surgery. So Goodell's classification is now regarded obsolete. So how do we monitor the depth of anesthesia? Enter the BIS monitor. BIS stands for bispectral index. It's a direct measure of anesthetic effects on the brain. This apparatus, and it's still used today, was heavily marketed, but not to healthcare personnel. It was marketed to the masses. I remember stories out there talking about patient recall, patients waking up on the table, but since there's muscle relaxation on board, they weren't able to do anything about it. In fact, I remember a movie made about it. So this device became mainstream to the point where they were requesting it when they went to surgery themselves. I know our anesthesia department didn't buy into this. They felt it cornered them and didn't feel it was 100% accurate with respect to assessing the patient's consciousness. However, the company says that it predicts the level of consciousness by measuring cortical responses under anesthetic agents. It takes an EEG signal, uses an algorithmic equation, and spits out a number on a screen that indicates the depth of anesthesia. Here's the monitor itself. Sometimes it can get in the way of some of the electrodes we place. Here's a numeric score that reflects the depth of anesthesia. Typically, they like to sit between 40 and 50. 80 to 100 reflects conscious awareness. 60 to 70 reflects light anesthesia. Less than 60 is adequate anesthesia, so they're adequately asleep, of less than 60, with 40 to 50 being a desired anesthetic plane. When it gets to 20, you'll most likely see burst suppression on your EEG. Here's a little pocket guide. It says the same thing right here. And this is what the little monitor looks like. Here's your number. So this little glass head has a bispectral index of 60, which would be adequately asleep, but they like it more between the 40 and 50 range. So let's talk about general anesthesia. A general anesthetic regimen is a reversible unconscious state. 4 components of anesthesia are achieved. Amnesia, which means decreased memory. This helps prevent recall of surgical procedure. Induction or hypnosis, or the loss of consciousness, the lack of awareness around your settings. Pain control, and the lack of movement. A balanced anesthesia is using effective, safe combination of anesthetic drugs to achieve all 4 components that we just talked about. It's best to use a combination of many drugs as opposed to using a large dose of one drug. The induction time is the onset of anesthetic regimen until balanced anesthesia is achieved. This can start in pre-op when they start sedating the patient. The recovery time is defined as a discontinuance of anesthetic regimen until the patient regains awareness. Recovery time can also be in post-op if they don't wake up in the operating room. Local anesthesia. This is where the surgical site is infiltrated by focal anesthetics or regional blocks. The patient is typically under conscious sedation. They give them medications to control anxiety, and they typically do it with minor procedures and sometimes major procedures. Critically ill patients who cannot tolerate general anesthesia will sometimes have a local. I know my mom had a total hip done under local anesthesia. She has horribly controlled blood pressure, and they thought it was too risky to put her under for that amount of time under general anesthesia, so they gave her local. She described it as being an out-of-body experience. She felt no pain, and she wasn't anxious, and the surgery was a success. A type of local anesthesia would be an epidural. This is where local anesthetics are injected into the epidural space. The medication goes outside of the cerebral spinal fluid. They use a large hollow bore needle with a small indwelling catheter surrounding it. Anesthesia is achieved by using a continuous infusion. This usually takes about 10 to 15 minutes for relief. What happens is it produces a segmental neuroblock, and this is used for longer surgeries or procedures and post-op pain control. This is the technique they use for women having babies. A spinal or a spinal block is a local anesthesia where the medication is injected into the subarachnoid space. It goes into the cerebral spinal fluid by using a small hollow bore needle. It's a one-time injection, and it usually provides immediate relief. And this also produces a segmental neuroblock. But this is for shorter surgeries or procedures and post-op pain control. This is a picture of epidural versus a spinal. Here's an epidural anesthetic, and as you can see, it's a bendable catheter, first poked through, of course, with a needle. They kind of retract the needle back, and then in goes the catheter here. Goes into the epidural space, and for spinal anesthesia, it goes directly into the spinal canal, into the cerebral spinal fluid. A peripheral nerve block is where they inject local anesthetic near the nerves that control sensation and movement into a specific part of the body. In the upper extremity, they'll inject the brachial plexus, median, radial, or ulnar nerve area, and in the lower extremity, they may inject the sciatic, femoral, obturator, or ankle. This is a definition of a half-life of a medication. A half-life is the time it takes for half of the drug to be eliminated from the body. We're going to talk about methods of delivery. You have inhalants. You can inhale a gas, or you can inhale volatile agents. Volatile agents are specifically formulated organic liquids that are vaporized. They're used for induction or maintenance of general anesthesia. But because they are a vapor, they're often irritating to the airways, and the patient will often cough as they're being intubated by using volatile agents. The objective is to provide hypnosis, amnesia, pain relief, and if exaggerated in large amounts, it can provide some muscle relaxant qualities. Inhalational agents are expressed in MAC. MAC stands for minimum alveolar concentration. This is the percent level of volatile agents preventing movement in 50% of patients after painful stimuli. 1.2 to 1.3 MAC can prevent 95 to 99% of patients from movement. We're going to talk about specific agents that are used or have been used. Halothane. A MAC was 0.77%. It's a volatile agent, which means it's a vapor that's nebulized. It was first used clinically in Manchester in 1956. They stopped using it, though, in the 80s because it was shown to produce severe liver damage in some, and it further complicated patients with cardiac problems. Enflurane or Ethraine. A MAC is 1.7. It's also a volatile agent, which means it's a vapor. It was developed in 1963 and first clinically used in 1966. It was used in the 70s and 80s and not much used at all today. Forane used to be the gold standard for intraoperative neuromonitoring. A MAC of forane or isoflurane is 1.15%. It also is a volatile agent. These come in little bottles. They pour it into the anesthesia machine and they're nebulized into a vapor. This is the one that became the most used for a long period of time after they stopped using ether. Forane is often irritating to the respiratory system while intubating. The next two are going to be newer drugs, sevoflurane or Ultane. We call it Sevo. A MAC is 1.71%. This is also a volatile agent. It was introduced around 1990. It's the second fastest inhalant regarding onset and offset, meaning you give them the Sevo, they fall asleep, you turn it off, and they wake up. And of course, that's desirable in surgery. This is a little more irritating than forane to the mucous membranes or the airway, so again, the patient would often cough during intubation if they are using Sevo. Desflurane is a drug often used today. 1 MAC of desflurane is 6%, also a volatile agent. It's the fastest onset and offset of all the volatile agents, again, meaning you turn it on, they go to sleep, you turn it off, they wake up. And it's not that fast, but it's much faster than the other agents. It's been known to cause tachycardia in some, and it also has an irritating quality to the mucous membranes, especially when given at concentrations greater than 1 MAC or 6%. Then we have nitrous oxide or N2O, and that's a gas, not a volatile agent. Nitrous was used almost on every case. What was good about nitrous is you turn that on so you can use less of other agents, so they wake up quicker. So it was more used as a supplement, and you'll still see it used today, but because Sevo and desflurane have those quick onset and offset qualities, they don't use nitrous as much anymore. What's nice about nitrous too is it gives you an amnesia quality as well, so they don't remember anything in surgery. Here's an anesthesia monitor. You're going to need to learn how to read these anesthesia monitors. This patient is getting desflurane. You can see right here it says des. You see an I and you see an E. I means inspired concentration. So they're delivering 6.6% desflurane. That's the uptake. The exhaled tidal volume is what E stands for, end tidal volume. They're breathing out 5.9%. Some machines now today might also have a MAC readout. So it's important to understand what MAC means as opposed to the percentage being delivered. And further, it's important to know the difference between what is being dialed in and given to the patient and what is actually being exhaled. As you can see, there's some waste volume in there. And why is this important? Of course, we know that anesthesia or any drugs could affect the neuromonitoring. So it's important to track these. So if we see changes in our data, we can correlate it with these anesthetic values. This is a little bit smeary, so sorry about that. But this is a patient that had Sevo. We started at 0.5%. They increased it to 1.7%. This is a cortical response. The red is our baseline. The yellow is the subsequent after they changed the Sevo, and you can see how it shifts your waves out. This is a brainstem response, and this is a peripheral response. These won't be changed as much. This is a cortical response, is where you'll see your changes more when the volatile agents or the gases or the inhalants are increased. Let's talk about IV fluids, another method of delivery. You can either give a bolus or a continuous infusion. A bolus is a large, fast dose when needed. It affects our waveforms dramatically usually because there's a big dose going in all at once. Continuous infusion by infusion pumps is best. It's a steady state infusion. We don't see big fluctuations in our data when they use continuous infusion. TIVA. You're going to hear this a lot when you're doing motor evoked potentials. TIVA stands for Total IV Anesthesia. So an example would be all IV administered anesthetic regimen, no inhalants at all. And further, even though it's an IV anesthetic, no neuromuscular blockade either, because for motor evoked potentials, we need to be able to record those muscles contracting. They used to call me the TIVA diva. When I'd walk in the room, I would be requesting special anesthesia. One tip that I have, if you're doing motor evoked potentials, talk to the scheduling office and say possible TIVA case or whatever wording you would want to use on the particular case itself. So anesthesia knows in advance this might be a case that they're going to be delivering total IV anesthesia. A couple of reasons. Some aren't a fan of total IV anesthesia. So that day when they schedule, they'll put somebody in that room that wants to cooperate with us. And second of all, they need to make sure they have the infusion pumps ready and increased medications of certain types ready. It helps them better prepare as well. This is just an example of maybe one type of TIVA regimen. In pre-op, they give something to take the edge off. And then induction, when they go to intubate the patient, they like to relax the muscles of the neck so they can easily put that tube down. So they'll put a short-acting, usually a non-depolarizing neuromuscular blockade, which we'll talk about in a second, for intubation called succinylcholine. They give a little narcotic, and then they give the propofol. Then they maintain throughout the whole case with the remifentanil infusion pump and the propofol infusion pump, sometimes other medications as well. And they use that BIS to monitor depth of anesthesia, the mean arterial pressure and heart rate. So they use the hemodynamics to help titrate the drugs to maintain a good anesthetic level. The disadvantage to TIVA without neuromuscular blockade is there's possible movement in the field. It's expensive because you're giving more IV anesthesia. It's sometimes out of the anesthesiologist's routine, so that makes people uncomfortable. And they often have a longer wake-up time. It takes a little more time for these drugs to wear off. And the biggest fear when we first started doing TIVA all these many years ago is fear of recall, where the patient wakes up on the table and they remember or feel pain and they remember being in surgery. However, there was a study out in 2002 that looked at 15,000 cases where they did motor evoked potentials and they had TIVA on all these cases. There was one report of awareness or recall. However, if you take any 15,000 cases, I don't care where it is, this could be coincidental. This does happen. It's very, very rare, but they determined this wasn't due to the patient having TIVA. Total IV anesthesia is now widely recommended as optimal anesthetic regimen for motor evoked potential monitoring. Muscle MEP thresholds are significantly higher and success rates are substantially lower with inhalational anesthesia. Even though you can record motor evoked potentials with small doses of inhalational agents, it's recommended, if the patient can tolerate it, to not use inhalational agents while monitoring motor evoked potentials. So this was a scan, so sorry about the quality of this, but this was a paper that I scanned. It's a case that I did. Right here is the left side, and this is the right side. It's a motor evoked potential. The red is the baseline. These are muscle responses to stimulation. So these are motor evoked potentials. The green is after they increase the desflurane or the inhalational agent to 1.8%. In this case, we started off with TIVA, but the patient was hemodynamically unstable. The anesthesiologist could not get the patient's blood pressure and heart rate under control, so we decided to turn a little bit of the desflurane on. Remember, 1 MAC is 6%, so 1.8% isn't very much. Then I ran a motor evoked potential, which is the green, and you can see here that it just totally obliterated my responses. Neuromuscular blockades. The introduction of neuromuscular blockades was done in 1942, and it changed the concept of anesthesia. It enabled the patient to be more relaxed in surgery, and the risk of movement greatly decreased. It achieved paralysis, facilitating intubation by relaxing the muscles in the neck so they can easily intubate the patient, and also it helps the surgeon. If there's a big spine case and there's a big incision where they have to retract a lot of muscle, by having muscle relaxants on board, it's less of a struggle for the surgeon to get those retractors in place. So you'll often hear them request muscle relaxation during exposure. Train of 4 is how we measure how much muscle relaxant is on board. Anesthesia can do it as well, but it's more important that we do it anytime we do any type of motor monitoring, like with EMG or motor evoked potentials. We likely are doing somatosensory evoked potentials where we're going to have stimulators on the wrists and the ankles anyways. So we would simply place electrodes on the hand or on the foot and stimulate the nerves to record from the muscles that are innervated by those nerves. Anesthesia sometimes will use the facial nerve, and then they observe twitches from the orbicularis oculi muscle. We will likely be using the median, ulnar, posterior tibial nerve, or perineal nerve. If for some reason we're visually trying to assess train of 4, which anesthesia does, you simply deliver 4 strong pulses to the nerve and watch the muscles that this nerve innervates. So for instance, we're going to deliver 4 strong pulses to the median nerve and watch 1, 2, 3, 4. These are 4 equal strong pulses. That means this patient is not relaxed and the muscle relaxant is worn off. 3 out of 4 twitches, that means they're 25% relaxed and 75% of the muscle relaxant has worn off. 2 out of 4 would be 50%. 1 out of 4 would be 90% relaxed. And of course, if you see no twitches at all, that means that muscle relaxant is on board and the neuromuscular junction is 100% blocked. What we're going to do though is put electrodes, we'll pretend this is the median nerve as well. We'll put electrodes on the hand, we're going to stimulate at the median or ulnar nerve, and we're going to record 1, 2, 3, 4. These are 4 pulses. These are compound motor action potentials recorded from a muscle. And we're going to measure from peak to trough. We're going to measure the amplitude. How tall are these waves? And you can almost visually see it. You have 1 strong twitch, you have a semi-strong twitch, and then you have 2 that's kind of faded away. One way of measuring it is measuring the ratio of T4, which is twitch number 4 right here, divided by twitch number 1. So in this instance, it'd be 20 microvolts divided by 100, and that's 0.2. Anything 0.2 or above is considered 4 out of 4, train of 4, which means the muscle relaxation has worn off enough in order to assess our motor evoked potentials or our EMG. Fade is something you're going to hear about. There is fade here, but if this number is less than 0.2, that means that there still is too much muscle relaxation on board to do our motor and EMG monitoring. Let's talk about types of neuromuscular blockade. There's depolarizing agents and non-depolarizing agents. Succinylcholine is a depolarizing neuromuscular blockade. It's very short-acting, about 3 to 5 minutes, and it's often used for intubation, right? It only takes a couple of minutes to intubate a patient. It's great for transcranial motors because it wears off right away. When they give it to the patient, you'll sometimes see them have muscle fasciculation or kind of odd twitching in their muscles, and that's normal with succinylcholine. However, in a small population, it's rare but it happens, succinylcholine can trigger malignant hyperthermia. Non-depolarizing agents block at the post-junctional membrane. Malignant hyperthermia. The patient experiences a sustained muscle contraction. It results in hypermetabolism, such as acidosis, tachycardia, hypercarbia, glycolysis, hypoxemia, and excessive heat production or hyperthermia. It's a pretty serious condition. Up to 10% of people who experience this may die, but others might be left with brain damage, failed kidneys, muscle damage, or impaired function of other organs. With respect to the muscle relaxations that we use, succinylcholine is the only one that can cause malignant hyperthermia. Non-depolarizing neuromuscular blockades. These are neuromuscular blockades that blocks depolarizing action of acetylcholine at the neuromuscular junction, right in this area during the synapse. This results in paralysis, and it decreases movement in the field. As we spoke earlier, they facilitate intubation and they help post-incision exposure. The three I'll introduce to you right now: norcuron or vecuronium, pabulon or pancuronium, and zimuron or rocuronium. Sometimes they call it rock. Here's the duration of non-depolarizing agents. So they're much longer acting. So if you know you're doing motor evoked potentials or EMG and you see they're using one of these three, know that these have a long duration before they wear off. And we will be constantly monitoring that train of 4 to assess the degree of neuromuscular blockade. Now there are reversals out there, and these are just 3 names of different types of reversals. However, you have to have one twitch before we can use a reversal agent. So the neuromuscular blockade has to be partially wearing off before these agents will work. What's interesting is some of these are used to increase muscle function in patients with myasthenia gravis. I thought that was interesting. Here's another reversal. It's relatively new, Sagamodex. This selectively binds to rocuronium and vecuronium, therefore terminating its neuromuscular blockade action. With this one, you do not need at least one twitch to administer, and this has been producing good results with very little side effects. There are many different ways we can help anesthesia, and train of 4 is one of them, but this is another one. We sometimes can tell if the patient's getting light during surgery. I don't want to say waking up, but they can get light, what we call light in surgery. It's usually, though, accompanied by increased heart rate or blood pressure, some spontaneous breathing, and maybe even bucking or coughing. If we're running EMG, we can see muscle tension. If you're doing SSEPs, your data starts looking messy. This is a nice clean SSEP, left side, right side. And if you notice here, these 3 derivations on the left and these 3 derivations on the right, they're looking messy and noisy. This is a cortical response where both of the electrodes are on the head. These subsequent 3 channels on the left side and on the right side are referenced to electrodes that are either on the neck or on the shoulder. So what happens when a patient starts waking up or getting light? They start getting tense. And this is just simply muscle activity that's interfering with our recordings. So if we start seeing going from this nice clean SSEP to something like this, where it's messy and disorganized, again, specifically in the derivations where you have an electrode that's on the shoulder or on the leg or on the neck, somewhere muscular, we can warn anesthesia telling them, hey, I'm getting some noise in my recordings. And they appreciate that. It gives them a heads up before they realize it's going on as well. And they can give more anesthesia so the patient doesn't do push-ups on the table. Benzodiazepines, we're talking about Versed, Valium, and Ativan. These provide an amnesic and hypnotic effect. They could be used to help prevent recall. Sometimes they give it preoperative to kind of take the edge off, and they only do that really these days if the patient seems really tense. It can also be used as an anticonvulsant. Large doses of benzodiazepines can act like a muscle relaxant. Narcotics. These are our painkillers. These can affect our data as well. So continuous infusions of these are best, not boluses. Large doses, though, can increase muscle rigidity. It can make our intraoperative monitoring look messy. And it can also interfere with reading your EMG. And again, here's a SSEP. And if the patient starts getting tense, you're going to see all this noise starting to be introduced into your waveforms. I have seen this happen with overuse of narcotics in the OR. Here are some of the narcotics that you'll see. You've got Demerol, which is short-acting. A lot of times that's just kind of given as a supplement if they feel that the heart rate's going up during surgery and they want to give a little more pain relief. Morphine, that's more you'll see after surgery. It's longer acting. Alfentanil is short acting. And then you have what you're going to see more in the OR with a continuous infusion. You've got fentanyl, sufentanil, and remifentanil. Fentanyl is 100 times more potent than morphine, and sufenta is 5 to 10 times more potent than fentanyl. And then remifentanil they like to use because it's very short acting. It doesn't linger around and the patient wakes up sooner. Induction agents, they do just that. They induce the patient to sleep. Some of them have anticonvulsant qualities, but these are used during TIVA to keep the patient asleep through an IV pump. Barbiturate-type induction agents. This is sodium pentothal or thiopental or Brevital. Sodium pentothal can cause laryngospasms. It does, however, have a rapid onset and offset, meaning it's short-acting. Some people call it the truth serum. That's what they used to give people to tell the truth. Brevital can possibly induce seizures, and it's ultra short-acting. These aren't used as much anymore. Non-barbiturate induction agents are used more in the OR. This is propofol or diprivan, the milky white substance. Some people call it the Michael Jackson drug. It's the one that he used to use so he could sleep at home. This can be painful when going into the IV of the patient. It is often given with lidocaine so it doesn't cause pain. It's used to keep the patient stable anesthetically, and it's short-acting, so it's good for TIVA and it's good for the entire length of surgery because when you turn off the infusion pump, they wake up quicker. If the patient has cardiac instability, sometimes they'll use ketamine. However, it's got an increased risk for seizure. And the same with etomidate. It's good for patients with poor cardiac reserve, but it also has a seizure risk. Ketamine and etomidate can initially increase our cortical evoked potentials. Not only are we going to track the medications that anesthesia gives, but we're going to track physiological considerations as well because they can affect our data. Hypothermia, or low body core temperature, can decrease brain metabolism. It also decreases nerve conduction, so it slows down the nerve conduction and it increases our latency, so they look like they shift. If the arms are cold, if they're sticking out from underneath the drapes, it can also slow down nerve conduction and cause shifts in our waveforms. Also, watch for cold IVs that are going in. They often try to warm the fluids that are going into the IVs, but sometimes they don't. And if cold fluid goes into the arm, one arm could be cold, and you can look like you have a unilateral change. Decreased blood pressure or decreased mean arterial pressure. Anything less than 70 may affect our data. And the systolic and the blood pressure should be above 90. Having said that, you need to watch for patients that are normally hypertensive. As I said, my mom has a crazy high blood pressure. She walks around on any given day at 155/90. She's been that way for years, and that's on medication. So if they keep her too hypotensive in surgery, so let's say they keep her at a mean arterial pressure under 70 when she's normally much higher than that, then she can have an ischemic event. So you should always maintain, or anesthesia should always maintain them within 80% of their norm. I used to always sit near the blood canisters. When I would see them filling up rapidly, I would get worried because a rapid blood loss can cause change in our waveforms as well. Some of the things you can do if you don't see the canisters is listen to the blood work when they call the blood work in. They'll yell out the hemoglobin or the H&H. If it's gone down, then you know that they're being hypoperfused probably. Has anesthesia ordered blood? If you notice they're ordering blood, then you know that there's an increased blood loss. Excessive blood loss can cause changes in our somatosensory evoked potentials. One other way we can help anesthesia is watching for malpositioning in surgery. Neuropraxia is a nerve stretch. It's more common in the brachial plexus area. Here's the patient's shoulder, and here's the brachial plexus right here. The brachial plexus is just a network of nerves. An injury here caused by prolonged malpositioning in surgery could cause a paralyzed limb, a lack of muscle control, or sustained numbness and tingling in the arm or the hand. Imagine going to sleep for spine surgery and waking up not being able to use your arm. What we can do is help by watching our SSEPs during surgery. This is an anterior cervical decompression and fusion. This is a typical positioning for that. They have the head turned because the incision's going to be right there. They have the shoulders taped so they can pull them down to facilitate a better exposure in the neck. Right there is the brachial plexus area. So you can see how if they have this tape stretched too much, it'll stretch this brachial plexus area. I've seen it many times where they had to loosen up the tape because I lost my SSEPs on this side due to taping. These surgeries have a real high risk of neuropraxia. This is a little subtle. This is an SSEP. This is the left side. This is the right side. The red is the baseline, and the yellow are the subsequent runs. Now you see the change here. These are the cortical responses or the brain responses. And you see the shift, and it's on both sides. That's probably due to drugs and anesthesia. However, if you look at subtle, you see how these are reproducing really nicely on the left side. And on the right side, we're losing amplitude and it's shifting out a little bit. The yellow waves are. This is a change. This was an ACDF. This is a real case. It was an ACDF. When they taped the shoulders, I started seeing this decline on the right side. They loosened up the tape and the waves came back. I earned my trophy for the day, for the week actually. They're so appreciative when you catch these things. The arms and the elbows should be at a 90-degree angle. The axilla and the ulnar aspects of the arm should be well padded. Here's where the ulnar nerve runs, and here's the padding, because laying on this ulnar nerve can do damage to the arm. Here's that brachial plexus area. It needs to be padded real well in there as well. They use a helmet-type headrest. This relieves eye pressure, and it has a mirror right here. Sorry the picture isn't that wonderful, but this is a mirror here. And in this headrest, it's an opening, so you can just look at any time and see the patient's eyes and mouth and nose. It's great for when you're doing motor over potentials. You have to put bite blocks in, and you can visualize that the bite blocks are in place. The neck has to remain relatively neutral, and I say chest piece, chest piece, chest piece, and I'll tell you why. This is another picture of that Jackson frame. This is where that head is. There's the mirror down here. Here's the padding for the arms. This is where the thighs rest. This is where the hips rest. Now these slide up and down, so of course any size patient can fit on here. This right here is the chest piece. The nipples actually should go right across that pad right there. This is a pad. If they're too far down, or we call it south, if they're too far south, then what's up top in your shoulders is your brachial plexus. You're going to put pressure on the brachial plexus and you're going to have problems. So you got to make sure this is across the chest and not across the shoulders. We learned that the hard way. This is a chest piece. This is a case where we had the chest piece in the wrong place. The red is the baseline. This is the left side. This is the right side. The red is the baseline. And then you see these waves started fading away. Here's one run, the next run, the next run, the next run. Again, one run, the next run, the next run. It basically started going away. We push that chest piece down to where it's more over the chest and away from the brachial plexus area. And you can see this last run here. Here it's, again, sometimes I call it wave wishing because I can see it and other people don't. But the waveforms start coming back, and they did recover. In the posterior cervical cases, sometimes the shoulders are taped and down and tucked. Again, the head needs to be supported as neutrally as possible, but you need to watch for too much break in the knees. You have to have the right amount of break in the knee. You don't want it to be bent up too much. A direct lateral interbody fusion is done with the incision on the side. The patient's laying on their side. The high risk here is that down leg. If it's not positioned right, then you can have changes in that leg that's on the bottom. I've seen this before as well. This is a dramatization, but this is a lower SSEP. This is the left side at baseline and the right side at baseline. This is later on after positioning. No changes. They all look nice and aligning with the baseline. And you can see the obvious change that includes the peripheral response. There's a shift. So my point is, we can help anesthesia, and more importantly, it helps the patient. The Stagnera wake-up test. You don't see this very often anymore because monitoring has gotten so reliable we don't need to do this. This is where anesthesiologist decreases the anesthetic level to a level to where you yell at the patient to wiggle their feet or move their hands during surgery, and it was mostly done during spinal correctional surgery. It was a gold standard, believe it or not. The patient doesn't remember, and it was a way of validating that everything was intact after they put in spinal instrumentation. It's very time consuming, and if we are doing monitoring at the same time, because I've done a few of these in my day, it's a nightmare. First of all, the patient's waking up, they're moving all over the place. Sometimes you lose some of your leads, you have to crawl under and put them back on. It's a very unstable anesthetic regimen. They lighten them up and then they dose them real fast once they move, and then it blows away your waveforms until you get back to a normal, steady state. You need to have a documentation policy that talks about how you're going to document, how frequently you're going to document, and what you're going to document. I always had little cheat sheets as well. So that way if they start a new drug and I don't remember how long, let's say rocuronium lasts, I have it right here. I used to always have these on my machine, so I knew exactly what they were giving and how long it would last. We would also give cards to the spine surgeons and anesthesia. Now, truth be told, some of them don't care for this, and I found out the hard way. So maybe get to know them first to see if they'd be receptive to something like this. I had one practice that wanted me to laminate these and put them on every one of their anesthesia machines, which was great. But it helps them as well. If I tell them we're doing somatosensory evoked potentials and motor evoked potentials, they know exactly what to expect, and then they know what the expected anesthetic regimen would be. Of course, they're going to do what's ever best for the patient, but at least it's nice for them to know. For instance, for somatosensory evoked potentials, I tell them why we do it and what the best anesthetic regimen is. It's hard finding that balance in the OR, especially since we're not there every day. We're only there during cases that are monitored. So where we are part of the team, sometimes it feels like it's an uphill battle getting what we need.